Hey everyone, we've got another heart today. This is specimen 874 in our collection. The heart would have sat in the chest like this. You can see we have the trachea and the lungs as well. Head or superior would have been here, legs or inferior would have been here, left would have been here, right here, anterior coming out towards the screen, and then posterior towards the turntable. So let's go ahead and find what we think is externally the right atrial appendage, and it looks like this would be here, triangular, broad-based. So let's go ahead and open up the heart here and take a look at what we have. So let me add some light to this. So we do in fact see that there are pectinate muscles that spill outside the confines of the appendage here, consistent with a morphologic right atrium. We find that there is an atrial septal defect here. So there is an intra-atrial communication between the left and the right atrium. And we do see the mouth of the coronary sinus here that's quite large, relatively speaking. And here's the tendon of Todaro here. Here is kind of where we would have expected the tricuspid valve to sit, because of that is the level of the right atrioventricular groove. And so the triangle of Koch would live here, meaning that the apex of this triangle would be here, which remember is where the atrioventricular node sits. So once again, the triangle of Koch in this heart, as in other hearts, is bounded by the mouth of the coronary sinus, the tendon of Todaro, and the right atrioventricular groove where the tricuspid valve would normally have its hinge point. And at the apex of this triangle is where the atrioventricular node usually lives. Now, obviously, at the level of the atrioventricular groove here is not where we find the tricuspid valve as we normally would. So why don't we take a look at this tricuspid valve in more detail? And first of all, right off the bat, we find the anterior leaflet here, which you can see isn't fully excavated from the myocardium here, right? So the term often used here would be incomplete delamination. So the anterior leaflet is quite large and hasn't fully excavated from the underlying myocardium. And then when we look at the posterior leaflet here as well, same thing, a very thin leaflet, very large, that hasn't actually fully excavated itself from the underlying myocardium. And you can see that the valve leaflets, the terminal edge is right here. All right. So here's the anterior leaflet, here is the septal leaflet here, also not fully delaminated, and then the anterior leaflet here. And we can see that these leaflets are quite large, not completely delaminated, and that in fact, this portion of what would have been ventricle is essentially now atrialized. And here is in fact the actual ventricular portion of this ventricular cavity here. And here are the kind of trailing edges of the tricuspid valve leaflet. So we are dealing with Ebstein's malformation here, where there's abnormal rotation of the tricuspid valve. Oftentimes people will say that there's inferior displacement of the tricuspid valve. This is actually not accurate, because if we look at how the heart sits here, and this is the anatomic or attitudinally appropriate way the heart would have lain in the chest, inferior would have been here, which means that the tricuspid valve, if it was inferiorly displaced, would have to shift downwards, leaving the heart. So in fact, this is actually a abnormal rotation of the tricuspid valve and not truly an inferior displacement, because the tricuspid valve really doesn't have anywhere to go inferiorly, and the heart does not sit like this, and so the valve is not inferiorly displaced. So if we look at it in attitudinally appropriate position, then we realize that this in fact is not an inferiorly displaced valve, just an abnormally rotated tricuspid valve. Once again, here's the anterior leaflet is here and is quite large. and isn't fully delaminated. Septal leaflets here, not really well delaminated from the underlying myocardium. And then here is the the inferior leaflet here, which is also quite large and not fully delaminated from the underlying myocardium. And then here is the ventricular cavity here. And that does appear to be a morphologic right ventricle. There's coarse trabeculations. There is a septomarginal trabeculation here. As we get into this right ventricular outflow tract, we do find a semilunar valve that appears to have 3 leaflets, 1, 2, and 3, and 3 sinuses to go along with that. We don't find any coronary arteries within this, so this in fact is the pulmonary valve. Here is the pulmonary trunk, and then right and left branch pulmonary arteries do arise from that. If we turn this heart to its back, here is a posterior aspect of the heart. Let's find here is the left atrial appendage. And so here is what we would expect is the left atrium. And here we find an atrium that is smooth walled. And then when we look inside this left atrial appendage, we do find pectinate muscles that stay within the confines of the appendage, consistent with the morphologic left atrium. We find our intraatrial communication again as well. We see that the left atrioventricular junction is guarded by a 2-leaflet valve that does not have connections to the ventricular septum. It's consistent with the morphologic mitral valve. When we look at the ventricle that it connects to, there are fine crisscross trabeculations consistent with the morphologic left ventricle. And then the aortic outflow is through here. And then here, in fact, is the ascending aorta here. And then you can see the head and neck vessels that come off. So a heart with Ebstein's malformation, and some key take-home points really are that the tricuspid valve in this setting is not truly inferiorly displaced, it's actually abnormally rotated.